Welcome, dear friends, colleagues, and viewers on MuniMeterHealth, your source of learning about cardiology and human heart awareness and illnesses. I'm Dr. Jaitly, your cardiologist from New York. Welcome again on MuniMeterHealth, where medical education, patient education are our prime interest, and we want to enhance that in order to improve the clinical outcomes. So once again, welcome to MuniMeterHealth. Without any further ado, I'd like to quickly get my housekeeping rules aside. Number one, if you're experiencing an emergency, please get to the nearest hospital doctor right away. Again. Two, for my valued students, residents, and fellows who are taking the boards and the exams, I consider these videos, these teaching slides mainly for enhancing your education. It's not a substitute to your syllabus. Please note, it could be a supplement to your syllabus. And three, there is no medical advice offered here. It's purely a medical education channel. So having said that, now let's we aim at providing the state-of-the-art of cardiology as well as the basic principles. So today I have an exciting subject called Angiotensin Receptor-Neprilysin inhibitor, or the ARNI groups of drugs. So just bear with me. It's a little busy slide, but as I walk through with it, it'll become much clearer as we go. So Angiotensin Receptor-Neprilysin inhibitor, they are brand new drugs that came around only about a year and a half or 2 years, and very little work or experience has yet to be ascertained and still judged. But the fact is that it's been around for only as many number of years, as I said, about a year and a half or two. But the fact is that it's really shown a great deal of improvement. One, there's a reduction in the cardiovascular mortality. There's a reduction in hospitalization of all heart failure patients. So all heart failure patients, that's where it's being used, and specifically so class 2 to class 4. And when people are using it in the setting of class 2 to class 4, these patients, again, it doesn't become the initial drug therapy, but the fact is that those patients who are repeatedly getting admitted to the hospitals for acute heart failure and their frequency is increasing, you certainly can advise them to have angiotensin receptor neprilysin inhibitor on them. Now, certain precautions before I always say that know the precautions more before writing the prescription. I always tell my students, so one of the precautions is you cannot combine this drug with any ACE inhibitor. You cannot combine this drug with another ARB. And if any of these two drugs are already on board with the patient, make sure you have 36 hours of free period before you start an ARNI. So between the ARNI and the rest of the ACE and ARBs, you should have at least a 36-hour period in between, just so that you know. Okay, so having said that, that's a major precaution. Two, of course, if you are allergic to one, say ACE or ARBs, because ACE inhibitors, they are notorious in causing angioedema, as you know, and therefore you will expect that to happen here as well. Now, neprilysin also does the same. Why? Because angiotensin level 2 levels go higher, and we'll explain that in a second. So now, remember, the basic physiology or pathophysiology in heart failure patients is that there are two processes going on. One is a detrimental process, and the other is a beneficial process. The detrimental process consists of the RAS system getting elevated, the renin angiotensin aldosterone system getting elevated, and the sympathetic nervous system SNS also being elevated. So this is being addressed with the beta blockers, as you know, in the heart failure. Okay, that's been around for like almost 20-30 years. So beta blockers are indicated now in all heart failure patients unless there's a contraindication. So this part is taken care of. This part needs to be taken care of by either ACE or ARBs. But now we are looking at something very important, and that's called the Vaso Peptides. Now the Vaso Peptides are beneficial arm. So this was the detrimental arm. It caused negative, it had negative prognosis to the heart failure patients. This has a positive connotation, a positive prognosis to the heart failure patients. Remember that. So vasopeptides are desirable. ANP levels are high, BNP levels are high, CNP levels are high, and bradykinins are high, and the adrenomedullin levels are high. So they are all elevated, and that is a beneficial effect. We like to see these levels elevated so that the patients can come out of the heart failure. It's very contributory to their compensation mechanism, whereas RAS and the SNS systems, they are detrimental, even though those levels are high, but they are detrimental to the heart failure system. So having said that, the beneficial effects of vasopeptides should be accentuated, whereas the detrimental effects should be brought down. So we have to get we have to accentuate the beneficial effects. That is the goal in heart failure therapy now. So what have we done so far? In heart failure patients, up until now, we were only addressing the RAS system. We were addressing the beta blocker system. We never addressed the vasopeptides in order to accentuate them. Now here comes a drug called neprilysin inhibitor. So first understand what is neprilysin. So neprilysin is an enzyme that is, it's a polypeptidase, which is constantly degrading all of these vasopeptides. Now what did you expect the body to do? You want the vasopeptides to be high in order to have the heart failure patients get better, right? So, but what is happening is neprilysin is constantly degrading them by converting them into various fragments. As a result, what is happening is the ANP levels, the BNP levels, and bradykinin are never high, and therefore neprilysin should be inhibited. If you inhibit this neprilysin, what will happen is that will be desirable. So that's a pure neprilysin inhibitor, which will raise the vasopeptide levels. All these levels, the ANP, BNP levels will be all raised. And that is very desirable. This is desirable. However, one of the problems with neprilysin inhibitor is, now there is again, there's always, I always say, it comes with a dual-edged sword. So neprilysin inhibitor, that's sacubitril, and we'll talk about sacubitril, that's the drug. That neprilysin inhibitor also augments the angiotensin levels. So you have to combine that with an ARNI group of drug. So an ARNI, like an angiotensin receptor and blockading drug, and a neprilysin inhibitor will be the ideal choice where angiotensin 2 levels can be brought down. So what have you learned so far? Neprilysin is a degrading enzyme that is existing in our body, which is constantly degrading the vasopeptides. Not desirable. We want to make sure that we augment these levels, so therefore we need a neprilysin inhibitor. However, when we combine a neprilysin inhibitor into the body, like sacubitril, purely, that's called pure neprilysin inhibitor, it will raise the angiotensin levels. So we need a drug which will have a combination of the two. We need an angiotensin receptor blockading drug, like an ARB, and the neprilysin inhibitor combination. That's what an ARNI is. So basically it is valsartan. ARNI is valsartan, and it's neprilysin inhibitor. Neprilysin inhibitor. Okay, so valsartan is what? That's an ARB, and neprilysin is the inhibitor. So they come in various dosages, just so that you know quickly. They come in 24, 26. They come in 49, 51. Don't ask me why. That's the weird way it's been like that, but that's the way they have completed the trials. If you look at the paradigm trial, I'll refer you to the paradigm trial, and that was conducted by Novartis, because that's the only company I think that makes the ARNI right now. And paradigm trials, they use these 3 dosages. Most of the time the patients belong to the second or the third tier dose. The basic dose of 24-26 was extremely weak. So most of the time the trials or the results were expected out of 49 and the 97 dose. Milligrams. Again, these are in milligrams. So just so that you know, and the drug is called sacubitril neprilysin inhibitor. Sacubitril valsartan. Sacubitril valsartan. And that is the drug. So sacubitril is the neprilysin inhibitor, and valsartan, of course, you know, is the ARB. Okay, so this is your neprilysin inhibitor there. So basically it's a combination of sacubitril, valsartan, which is now being used in our armamentarium for heart failure patients, where RAS system is being inhibited, and the vasopeptide levels are being accentuated in with this drug. So that is a dual action based on the above philosophy in the heart failure patients that I just shown you. Okay, so in summary, we now have a drug not only which is an angiotensin receptor, but it's also an angiotensin receptor neprilysin inhibitor, if you will. And that's what makes it a difference, because you want to have the vasopeptide levels accentuated, you want to have the RAS and the SNS systems decreased because they are detrimental. You don't want those levels to be that high. You want these levels to be high, the ANP, the BNP, and the bradykinin. Okay, so again, it's a very short talk on ARNI group of drugs. They're brand new, as I said, and the side effects are obviously angioedema, cough that comes with it, and cough could be a nuisance here. But again, somebody who's allergic to ACE or has shown history of angioedema should totally avoid these drugs. Again, you have to watch the potassium levels, kidney functions, KFTs I call them, and then you have to watch the potassium levels, as I said, look at the BUN and creatinine obviously, and then prescribe these patients with this. Again, blood pressure drop can occur in these individuals, specifically so because you're using two agents which can really deplete because they cause severe natriuresis and water loss as well, because that's the way how these drugs will work. Again, the sodium depletion will occur, but the clear advantages are the cardiovascular mortality is reduced and the hospitalization is reduced, and these are your endpoints that have been done through these trials or paradigm trials, which have really shown that class 2, class 4 heart failure patients can benefit very